Hello.
Hello, Dr.
Am
Vishakha.
I
Good
audible?
evening.
Good evening, ma'am. Should we start the session?
Yeah, sure. Am I audible?
Okay.
Am I clearly audible?
Yes, ma'am, you're clearly audible.
Okay.
Good evening, everyone. Welcome to another webinar on troubleshooting in endodontics, proudly presented in collaboration with Medical Aura Community. And I'm your host, Dr. Vishakha Singh. Over the next 60 minutes, we will explore the clinical implications of troubleshootings in endodontics, and it will provide you with practical tips and takeaways. And it is my immense pleasure to introduce our esteemed speaker, Dr. Mohnisha Shahi, ma'am, a gold medalist and accomplished dentist with exceptional expertise in complex dental cases. Her area of expertise include root canal therapies, periapical surgeries, cosmetic dentistry, and comprehensive patient care. She's a pioneer in interdisciplinary approach with two original researches, four scientific publications in reputed journals, and several national as well as international publications during her PG and beyond to her credit. As the founder of Dental Care, she runs a thriving private practice and she has been mentoring young dentists in Nepal since 2022. Please join me in welcoming ma'am as she guides us with her valuable insights with us. Ma'am, please proceed with your presentation.
Good evening, everyone. It's truly an honor to be here today to share my knowledge on the topic troubleshooting and endodontics. And thank you so much, Dr. Vishaka, for the wonderful introduction. But I would like to give my introduction again. Everyone, I am Dr. Mohnisha Shahi, and I come from a beautiful city of Kathmandu, Nepal, a place known for its rich history, cultural heritage, and warm hospitality. And I'm somebody who has always believed that learning is a never-ending process. And with this lecture today, I really hope that I'm successful in delivering the like some knowledge to you. And I am definitely going back home with a lot of taking a lot of knowledge from this platform. Um, like before, uh, I'm not able to happen here. Yeah. So before I begin, I would like to take a moment to express my gratitude to my family, to my friends like family, to my institutional family, to my clinical team, and to my homies, to my family, for always being there. They have been my forever support. Their belief in me has always been there and has always been my strength, and I wouldn't be here without them. And I'm actually, and I also would like to I would also like to, yeah, express my gratitude towards this online platform, and I would like to thank them for giving me an opportunity and for including me in this Endo series. This is my very first time delivering lecture in any Indian platform, and I was very much looking forward to it. And I'm actually very much elated to be a part of this. As the date is 8th of March today. It's International Women's Day. I would like to wish every one of you a very happy Women's Day. And I'm glad that I'm surrounded by these wonderful women in my life who have been the source of inspiration to me since forever. And I feel blessed to have you all around. We have always celebrated each other's win and always have made sure that we are in each other's low too. So it's my immense pleasure to share this platform with these incredible ladies of my life. So happy Women's Day to all of you. So now, with the blessing of the Almighty, I would like to begin my presentation today. The topic of my presentation today is troubleshooting in endodontics, identifying and overcoming the common challenges. And I will covering my presentation under all these headings. And to start with the introduction, endodontics is the branch of dentistry which deals with the pulp tissue, with the root canal anatomy, and the area that is surrounding the root, which we called as periradicular region. And the success of the endodontic treatment depends on all these steps of the root canal therapy, right from the diagnosis and treatment plan to access opening to shaping and cleaning to obturation to post obturation restoration. As I say so, each step of the root canal therapy also comes with its own challenges, with its own issue, which brings me to today's topic of lecture, that is troubleshooting the challenges that we face in the day-to-day endodontic practice, where we are going to learn, where I am going to discuss about the various issues that we face during endodontic treatment. I'm going to tell them how we can prevent them, about the prevention of those issues. If at all this problem happens, how we can solve them, or how can we overcome them. Okay, so with that, moving forward, so since it is a very vast topic, you all, it's a very vast topic, so I have just categorized in such a way that it is going sequentially. Okay, it is going sequentially, stepwise, in the root canal treatment procedure. Okay, so that it will be easy for you all to understand it, like and it is going to be easy for you to correlate it clinically. And it is basically, it's a very clinical based presentation today, so I hope you are able to correlate with it. And if at all, if you have any problem, there is a chat box down there. You can always put your query there, and then we will discuss it at the end of the presentation today. So to begin with, let's okay, talk about pre-operative challenges. So we face issues and challenges even before we are doing the access opening itself, which include incorrect diagnosis and treatment plan. We face issues during the anesthetic phase. We face issues during the isolation phase as well. Okay. So talking about the incorrect diagnosis and treatment plan, see, most of you must have attended Dr. Sarita's lecture, which was the first lecture of our endo series. So she has covered diagnosis and treatment plan really well in that lecture. Okay, so I'm not going to go in very much detail of it. So I'm going to just I would just like to give a clinical like knowledge, clinical tips and tricks to you all in this presentation. So, as she also mentioned, diagnosis and treatment plan is the most important, is the most important part of any treatment that we are doing, okay, in dentistry. And regarding endodontic treatment, I would like all of you to please keep this in mind, that not every painful tooth requires an RCT. Okay, I'm gonna give you a very good example, like once I'm done talking about all this. Okay, so like proper clinical examination has to be carried out. Okay, and obviously along with the radiographical examination, which is going to give you a good conclusion regarding diagnosis, and accordingly we will make the treatment plan, right? So like at times the patient will come to you with the very definitive history of pain, like okay, I have particular, like I have this kind of pain in this particular this tooth, right? But sometimes there are so many patients which will come to your operatory, to your clinic, like which will give you very vague history. Okay, and that is the time when you are supposed to do like proper clinical screening. Okay, which includes like you have to ask all sort of questions, you have to record like history of pain well, you have to perform some clinical tests if necessary, the pulp sensibility test, the other day Dr. Sarita was explaining it so well, right? And yeah, clinical examination has to be carried out well by doing percussion, palpation. If there is swelling, then just note that. And of course, along with the radiographical an examination, right? So after once all this clinical examination, radiographical examination has been carried out, you will come to one conclusion regarding diagnosis, and accordingly you will make the treatment plan, right? And yeah, that is how you're gonna do the diagnosis. Okay, and I know there are so many cases which will appear in your operatory, like one or the some other day, which has high tendency, which has high potential to get misdiagnosed. Okay, so I'm not gonna like talk a lot about like this. So such lesion could be like endoperio lesion, like cracked tooth syndrome, or in the trauma cases it is actually very hard to come to a conclusion regarding these cases. Okay, so like I'm not going to go in detail like how you're going to diagnose it, or like what are the treatment plans are like that for this particular teeth. But what I'm telling you is, what I want to like pass on to you, is that if you are not sure, if you are not sure of any diagnosis, or if even the slightest of doubt if you have, then please refer this case, or at least take an expert opinion. Okay, there is no shame in doing that. Okay, so do not jump onto the random diagnosis and then treatment plan, and just like randomly do the case like that. Okay, just please take the expert's opinion. Okay, So I was talking about this thing, like not every painful tooth requires an RCT. So I would like to give you an example which happened to me like just few days back. Okay, one of the patient, old lady, she came to me like aged around like above 60, 64, 65 years old, old lady. She came to me, and then she was very much, like specific about her tooth, like, okay, this particular molar is giving me problem. So the problem was in the 2 6, and she was saying that she has been in a terrible pain since 1 month, and like she has a lot of sensitivity in that tooth. So she had already gone to one dentist before she came to me, okay, one day before. And that dentist has already, spoken to her and motivated her and convinced her to the core to get the RCT done in that particular tooth. To her fortune, to her good fortune, she landed up, taking another advice from the other dentist, and she came to me. And when I saw there, I could see there was there was mild TTP. There was slight TTP present in 2 6. All right, and I could see a lot of food was getting lodged in that area. In between 2 6 and 2 7, there was a lot of food lodgement. The moment I took the food that was lodged in that area, I could see a huge class 2 decay in there. Okay, then I asked patient to go for an IOPA in that tooth. When I saw the X-ray, when I saw the IOPA, to my amazement, the decay was very small, like just limited to the enamel and dentin, and not even, approaching pulp. It was nowhere near the pulp's vicinity. Okay, so it took me quite a time to convince her, because she was so adamant in getting the, root canal treatment done in that particular tooth. Then it took me quite a time to convince her that no, you just need a bit of oral prophylaxis, okay, like proper prophylaxis in that area. And I, gave her a good restoration with a good margin, adapted margin, along with good contour and contacted contour. And 3 days later, she came to me thanking me. She was totally out of pain. She was, sensitivity free, and she was happy. Okay, so that is the reason why I am saying, please do a proper clinical examination and radiographical examination if needed, in order to come to any diagnosis and like make treatment plan accordingly. And not every painful tooth requires an RCT. Okay, so moving forward, yeah. So yeah, so in the preoperative challenging issues, we face a lot of issue during the anesthetic phase itself, right? Hot tooth. This is every one of us like favorite words. Let me say, even if you and I are at blame, okay, I think I might have also done this, like the landmarks that we have chosen for, especially we face problems in achieving the anesthesia, particularly in the lower molar. You all will agree to that, right? So so what happens is, usually we are the one at blame, to be blamed for not getting the proper anesthesia. But what we like to do is we put blame on the tooth, saying that okay, this is hot tooth. So basically, you all must be are very much aware of to hot tooth. But to those who are not aware of hot tooth, hot tooth is the tooth with the acute inflammation because of the irritated nerve in it. No matter how much block you are giving, the tooth is just not gonna get numbed. Okay, so that is when we prefer saying, okay, this tooth is a hot tooth. It is not getting numb at all, no matter how much anesthesia infiltration we are giving. Okay, so in this kind of case, the even the literature suggests that there are supplementary injection that you can give in order to get a good anesthesia in such kind of cases. So yeah, there is supplementary injections such as like intraligamentary, intrapulpal, and intraosseous injection anesthetic technique. Anesthesia technique can be can be considered. So intraligamentary, in the intraligamentary, what you can do is you can take the thinnest needle possible, like 30 gauge needle you take, and then penetrate the needle on the gingival sulcus, preferably in the mesial or the distal aspect of the tooth. Okay, even the slightest 0.2 ml, 0.3 ml goes in the in the in the ligament, in the intraligament area, it is gonna give wonderful result to you. Okay, and intrapulpal, you all must be aware of intrapulpal as well. We directly give inject the anesthesia onto the pulp. Personally, I don't like to give intrapulpal, because already the patient is in so much of discomfort, and then again you are irritating that pulpal tissue. not a good idea. Okay, for me personally, I don't go for intrapulpal injection method. One another wonderful technique is intraosseous, where you directly, inject the anesthetic in the bony tissue. Okay, there is this dental system called Stabident, as you can see in this picture here. So this dental system has a perforator, a driller, a very thin sized driller. You can see here, which is attached to the quadrangle handpiece here, and there is a small needle also. Okay, anesthetic in the anesthetic this syringe. So what we do is we can perforate a small hole. We can make a small hole in the bony tissue with the help of a perforator, and like you can see a small hole, very small tiny hole in it, and then you can directly easily you can push the needle there, and you can give this intraosseous anesthetic solution there. Okay, so and it works wonderfully. Okay, so yeah, that is what. And moving forward, another issue that we face during the anesthetic phase is ineffective anesthesia. It could be because we are not following the proper landmark. Let's say like in the IANB, as you can see in the picture here, we have to follow. We have to teach ourselves first. Okay, where I'm gonna land up. My needle like onto. So you have to read the landmarks properly and then follow the landmark. It is definitely gonna give you a very good results. Okay, and there is another thing, to those which are not very much aware of it. We have been using since like decades, we have been using 2% lignocaine in order to achieve anesthesia in our dental practice. But there is this anesthetic solution 4% artican, which has worked, which works like wonder in the in dental practice. Like it is so much better than 2% lignocaine. You can go through this article that I've quoted here, and I've just like made a brief difference between 4% artican and 2% lignocaine. Like talking about 4% artican, it is so much better in all the aspects. The onset of action is faster than lignocaine, the duration of action is longer than lignocaine, it is more potent, and it is said to be more efficacious than lignocaine. And since the 4% artican gets metabolized, very little artican gets metabolized in the liver, so it is very safe in the hepatic patient also, as well as in the kidney patient. Okay, and whereas 2% lignocaine is not advisable at all in the hepatic cases. Okay, so and also the 4% article has shown to have superior penetration in the bone tissue. So even if you are giving intraosseous injection, 4% article is gonna like work like wonder. Okay, in order to give you a good anesthesia in that region. Okay, and another, yeah, there are so many studies which also suggest that, specifically like there are studies for the anesthesia of the lower molar. So they have suggested that if you are giving patient pre-medication as analgesic, like if you are giving analgesic just before the you are giving anesthesia, like it is gonna give you better results. Okay, the numbness is gonna be there, like the it is gonna be more effective than the injection. It's alone. Okay, that is there. Another issue that we face is painful injection. So there is this term called two-stage anesthesia. I think like even you and me, everyone is following that in most of the cases. What we can do is, in the first stage, what we can do is we can apply an anesthetic gel. Okay, there is an anesthetic gel that you can find in the market. So you can just use a small bud, or sterilized bud you can use, or sterilized cotton pellet you can use, and just like take a bit of the anesthetic gel, and you can just rub it in the area of interest. Okay, and let it be there. Let it settle for like 1 to 3 minutes there for a while. Let it go in a deeper tissue and work well. Wait for 2 to 3 minutes, and then after that you inject. In the second stage, what you can do is you insert the needle, okay, in that tissue. It is going to be less painful. Okay, and also I would like to address this that more than the insertion of needle, it is the injection of the penetration of the anesthetic solution into the tissue, which is actually causing more pain. Okay, and it is suggested that slower the penetration of the anesthetic solution inside the tissue, like it is gonna give you more, it is gonna be more comfort. Okay, so like slowly inject the anesthetic agent in the tissue. Okay, and there are also so many these studies, they have shown that preheated anesthetic solution has shown to have lesser discomfort than the anesthetic solution which are in the normal room temperature. Okay, so there is this one article that I have mentioned here. In this, what they have done is they have put the vial, not vial, sorry, the cartridge, or they have put the syringe, loaded syringe in the composite warmer. Okay, for about 2 to 3 minutes, and they have set the temperature to 42 degrees centigrade, which is slightly higher than the body temperature. Okay, so this has also said to they have helped in achieving the anesthesia, giving anesthesia with less discomfort. Okay, so yeah, and moving forward, yeah, so let's begin with some issues that we face during the isolating phase. So isolation here, I am more like concentrating on the rubber dam application. So yeah, clamp displacement can be of can be a big issue while we are placing the rubber dam or clamp on the tooth, right? So if the clamp gets displaced, there is higher chances of getting aspirated, which may land up the dentist or you or me in a medical legal issues, which we do not want, right? So I think somebody's audio is on. Dr. Anu. Dr. Vishakha, can you please
Yes,
give
ma'am.
Dr.
Yeah,
Anu,
yeah, sure, sure.
yeah, can you please give her
Yeah,
a call and then ask her to, yeah, thank you.
yeah, sure, sure, sure.
Hmm. So, like, obviously, like the aspiration of clamp is gonna be a big hazard, and you won't want this in your operatory, right? You don't want this in your clinic. And for this, the the like you only have to like do floss tie, or you can just tie some dental floss to your clamp so that it doesn't even if it gets displaced, it does not get aspirated to inside the patient's mouth. Okay, so that's what you can do. And some other problem that we face in the isolating phase is, as you can see in the picture here, seepage from the rubber dam sheet. Can you see this thing, right? You have like put the dental sheet and then clamp so nicely, well adapted, it looks very well adapted to every tooth, but then can you see this seepage, right? This should not happen. Okay, so for this there are some like liquid dam, and then there are some what do you say, gingival protector barrier protection barrier also can be applied. And for people like you and me who are so jugadu, who want to do a jugad in everything in dentistry, you can also put some Teflon tape. Okay, you can just squeeze in some Teflon tape to get the seepage free rubber dam rubber dam assembly. Okay, so yeah, in order to get like good isolation, you can do that also. Fine. And talking about the soft tissue injury and pain around the clamp, you see, soft tissue injury is gonna happen only if you are putting the, you have to be very sure that, as you can see in this picture, the four prongs of the clamp should be seated on the four line angles of the tooth. Okay, not on the soft tissue. So that's how you're gonna prevent the soft tissue injury. Okay, and about the pain because of the clamp, you are always, even if you are treating the non-vital tooth, like we usually don't give block or infiltration in those kind of cases, right? But if you are putting clamp during the isolation or rubber dam placement, like always make sure that at least you are giving some topical anesthesia, or at least give us like little bit of infiltration anesthetic with of the anesthetic solution around that area. Okay, so that the tooth will be, or the soft tissue pain will not be there. Okay, and talking about the crown fracture, always be very mindful. I'm mindful of the fact that of the thing that you are not choosing the wrong tooth to be clamped on. Okay, if you are working like like suppose you are doing like isolation, if you are doing RCT on 4/6 and the tooth structure is like very bad, okay, it's like it's very very like grossly decayed tooth, and if you are supposed to do RCT in that particular, better you go for this multi-tooth isolation, okay, don't go for the single isolation, okay. So that is how. And another thing is isolation for irrigation. Yes, a day before yesterday, Dr. Anu mentioned like really really nicely about the pre-endo build-up. You see, you get like one thing is you will get a 3D, like you will get a reservoir for the irrigants to stay in place. Another thing is, if you are giving, you see, can you see in this picture, if you are making a 3D like pre-endo build-up, the even the rubber dam sheet is gonna get adapted really well around that tooth. So yeah, that is one another tip that I want to give you. Yeah, so now here we are done with the pre-operative phase. Now moving on to the intraoperative phase. Again, I have made it in a very stepwise sequential manner. According to the step of the root canal treatment, that is root canal treatment procedure. Okay, so we'll start from access cavity preparation. So there are various issues that we face during the access cavity preparation. The first and foremost being the not being able to locate the canal. Okay, so there are always some challenging cases in which we face, in which we face the problem of locating the orifice or canal, such as in cases of calcification, unusual anatomy, right? So, and extra root and extra canal like that. And I'm gonna give you a common solution which will fit for which will fit for all these like unusual anatomy cases, okay. First and foremost being the use of magnification with illumination. You see, it's a very very good thing if you have microscope in your operatory. If at all like you don't have microscope, I would highly recommend everyone to get a invest in some good like eye loops, okay, with good illumination, okay. What I believe is what everyone should believe and everyone knows, that you cannot work in the area where you cannot see. You can only work only when you are getting like a good area to like when you get like good visibility with good illumination, only then, okay. So magnification is going to give you a freedom of knowing every nooks and corners of like what is going on inside the tooth, right? So use of the magnification with illumination is like highly highly recommended. And also like we have to have like knowledge on the law of orifice location, which I'm going to discuss later. And you have to do like proper radiographic analysis, okay. So this is my take on it. Whenever I am taking a diagnostic x-ray, I prefer taking it in like three different angulation, okay. One with the normal horizontal and vertical angulation, one in the mesial shift, and one in the distal shift. So usually what happens is I'll give you one example, like for what do you say, this entomolaris case. So radix entomolaris case is it is a molar, lower molar, with the extra like distolingual root, okay. I'm not talking about the canal, I'm talking about the root, okay. So there is the presence of extra distolingual root, okay, in the radix entomolaris case. So many a times what happens is, when you are taking a normal, since we are looking at the 2D image, right, 2D IOP is a 2D image, sometimes what happens is that distolingual root may get superimposed behind the distobuccal root, okay. So in that kind of case, this 3D like this three angulation or the mesial and distal shift of the IOPA is going to help you, is going to be of a great help, okay. So like you don't have to go for, again, like in places like Nepal and India, I'm sure the cost of CBCT is like really really high, and not everybody is like, it's very difficult to motivate patient to get a CBCT, although it is for their good, but still like it's very very hard. It takes, I think it costs around like 3,500 to 4,000 for segmental CBCT in our country. right? And I'm sure even in India it costs around 1,500 to 2,000, right? So not everyone gets motivated. So like with this very small trick or tip, I would say you can just find out you can better like you can do the radiographic analysis in a better manner, okay? And also you with the use of correct armamentarium, there are different kind of burrs, ultrasonic tips, hand pieces and dies, which I'm going to discuss after this. So yeah, with the use of the correct armamentarium, we can again get rid of this problem, okay? Now, talking about the another point, full coverage restoration. See, we don't know what is happening under the that restoration, right? We don't know what is happening under that crown. Okay, but if you are very sure that the canal adaptation, the margins are very good, and the cap, the crown is not causing the patient any problem. It is only the root canal treatment which was treated badly before has to be treated again. Only if you are very sure of it, I suggest you to go through the restoration or cap itself. Otherwise, in most of the cases, I would advise you all to take out the cap or the full coverage restoration, and then start with the RCT or re-RCT treatment that you are going ahead with, okay? And if you are cutting through the crown, sorry, if you are cutting through the crown, if you are dealing with the ceramic, you can use normal diamond burr. And if you are cutting through the metal, you use transmetal burr or carbide burr, okay, to cut through it. Now talking about another issue that we can face during the access cavity preparation, that is angulated and rotated tooth, okay? See, like we have to follow the long axis of the tooth, okay? See, like what I do is I use periodontal probe, okay? And then, like for example, if I'm looking at the lower premolar, okay, what I do is I just check the angulation, okay? From I just put like probe like from the cusp tip to the CEJ area, and then I follow that direction. And also with the help of radiograph, okay, you have to see the radiograph, because radiograph is gonna give you even better angulation, like knowledge of the angulation, right? So you have to place your burr accordingly. You have to incline your burr accordingly along along the long axis of the tooth, and work like accordingly, okay? If you don't do so, you will end up perforating that tooth for sure, okay? And also please follow the law of orifice location. I'm going to give a brief discussion, I'm going to like give a brief knowledge about it in the later slide. But yeah, you have to follow a good you have to follow the long axis of the tooth, and also like radiographic analysis has to be done, and law of orifice location has to be followed well, okay, in such kind of cases. Now coming towards treating the wrong tooth. This might seem very impossible to you guys, right? But this happens, and this has happened in front of me also. I have seen such kind of disasters happening, and luckily it hasn't happened to me yet. But I cannot promise you all that it cannot happen to me in future. Okay, so you have to be very mindful and very much like aware while you are treating any tooth, okay, while you are working. So so there are two reasons, okay? For me there are two reasons. What happens is usually at times what happens is patient does not give, they give very vague history, okay, very vague history, and then it is just impossible to locate, like okay, this particular tooth is having pain, or this one. So I'm again talking about the misdiagnosing, okay? That is the reason why I was telling you all that if you are not, even the slightest of doubt you have regarding diagnosis, please take an expert's opinion, okay? So you have to carry out all the clinical examination nicely, and just be very sure, very sure about the diagnosis that you are making, okay? Only once you are very sure that okay, this is the tooth that is causing the problem, only then like you are supposed to start with the treatment, okay? Another reason how you can go with treating the wrong tooth. See, there are so many cases without decay, okay, no cracks is seen, nothing, very normal looking tooth which has a primary reason, okay, which has to go for root canal treatment, but because of the primary perio reason, But in like in that kind of cases, you won't be able to differentiate between normal tooth and the tooth to be treated. And for example, let's say the lower premolars, upper premolars, upper molars, they look almost the same. The lower molars, they look the same. So I just want you guys to imagine, so one patient came to your operatory, and you are supposed to treat 3 4, okay, your lower left first premolar. So you are supposed to treat 3 4. You give anesthesia, the like the area is anesthetized very well, the patient is okay, there is numbness you have achieved. Now it's the time to isolate the tooth. Okay, you clamp the tooth, you put the rubber dam assembly, and then you started working. You finished up case in like 1 hour, and then after you are finishing, after you finish the case, you took out the clamp from the tooth, and then you see there you have treated the wrong tooth. You have treated 3 5 instead of 3 4. Can you imagine happening that? Yes. So like mishaps do happen. Okay, but how can you save yourself from such mishaps to happen? What you can do is, number one, it's always, it is recommended to go for this multi tooth multiple tooth isolation rather than single tooth isolation. But even if you want to go for single tooth isolation, what I suggest is, once you are very much confirmed with the diagnosis and okay, this tooth needs to be treated, just put a mark on it. Okay, either you can mark it with some, like, marker pen. Okay, either you just like mark it with a marker pen, or you can give a small drill, any which ways you are gonna give, like, make an access cavity preparation on that tooth. So just like make a small drill before you are putting the rubber dam assembly in there. Okay, so these are two tips that I want to give you in this one. Okay, I hope you understood what I'm trying to convey. Okay. Yeah. So yeah, like I was talking about the armamentarium, right? Armamentarium in the operatory. Okay. See, magnification is just irreplaceable. Okay, just as important as the aorta. Magnification is also like it is important. Okay, so then if you have microscope, very very good. If not, then please go and, like, buy and invest in a good dental loop. Okay, and then front surface mouth mirror, hand pieces are there obviously, and then these burrs are of great use. Endozet burr, you all are very much aware of that. This transmetal burr is very much useful in cutting through the metal restoration or metal prosthesis that I was talking about before. This Mune's discovery burr, since you can see the head of the burr is very small and the shank of the burr is very like long, it's very helpful in like finding the orifice, locating the orifice. Okay, so yeah, these burrs and all these explorers and excavators, and these are very useful in orifice location. Yeah, this is another thing, ultrasonic unit and tips. Okay, this work like wonder. Okay, everyone should have ultrasonic tips in their operatory. Like obviously it is gonna give you it is obviously it's going to help you in orifice location, but with great visibility. Okay, with great visibility, and also it is going to give you a great results. Okay, yeah, that is all. And yeah, other ways to find the orifice location are these. So these actually, the dyes, the white line test, red line test, these are like nothing but dyes, are like simple chemical dyes, right? And then white line is nothing but the debris, debris from the tooth, which is coming out when we are using the ultrasonic tip inside the cavity and under the dry environment. Okay, and red line is nothing but the blood that is oozing out from the hyperemic pulp or the vital tissue that are present. Okay, so these all, the dyes, white line test, red line test, they are nothing but they serve as visual guide to locate the orifice. Okay, so the dyes, they are going to settle in the fins and orifice and isthmus. Same with the white line also, the white line test also. In the white line, the this smear layer or the dust that is coming out from the cutting the tooth structure, that are gonna get that is gonna get accumulated in these orifices, fins and isthmus, again serving as a dentinal map, you can say. Similarly, red line test. Okay, So this is how we can, like search for orifice, or if there is any fins or isthmus or any organic tissue that is left inside, right? So this is how we're gonna locate them. And there is this term called champagne bubble test, which with the help of sodium hypochlorite we can achieve this. So we all know that sodium hypochlorite, they dissolve organic tissue, right? So when, if there is any like necrotic tissue or organic tissue that is left in the, fins or, orifices or isthmus, once we flood the, pulp chamber with the high concentrated sodium hypochlorite, it is gonna, there is gonna be some effervescent effect. Okay, there is gonna be some bubble that is coming out from the area where there is organic tissue left. Okay, and that's how you're gonna, okay, see. And again, like, you cannot see just with the, naked eye. You have to have magnification. All of these things are coming to zero if you do not have good visibility, okay, along with good illumination. So yeah. Yeah, moving forward, I was talking about the law of orifice location. There is this really good, this what do you say? This yeah, idea where Krasner and Rankos have given in order to find the orifice in the tooth. So yeah, there is law of centrality. So it says that the pulp chamber is always located in the center of tooth at the level of CEJ. Okay, what I do in my practice is that, like, I take the periodontal probe and I just see for the, like, I check for the CEJ and I just mark that mark. Okay, let's say it is like coming like 6 to 7, 7 to 8 mm, 8 mm, let's say. Okay, and then I mark the same on my burr and I don't go beyond that level. Okay, that is the place where you are going to find your orifice in. Okay, so always make sure that you are following the, long axis of the tooth. You should go parallel to the long axis of the tooth. And about the depth of the burr, you cannot go beyond CEJ. Okay, like, limit yourself to the level of CEJ. Fine. Law of concentricity. The walls of the pulp chamber are always concentric to the external surface of the tooth at the level of CEJ. So whenever you see a bit of bulge, okay, external bulge at the level of CEJ, there is always gonna be the bulge in the uh, there is gonna be bulge in the chamber also. Okay, pulp chamber also. So that always, like, you just always have to follow the external surface of the tooth. Always see the external surface and accordingly make it, like, design your cavity also in between. Okay, and always you're gonna find some, hidden orifice in that bulge. Always like that. And especially this kind of like, this happens in the this radix entomolaris and paramolaris case. Okay, law of CEJ, the distance from the external surface of the clinical crown to the wall of pulp chamber is same throughout the circumference of the tooth at the level of CEJ. It's almost the same thing. Law of symmetry 1. Except for the maxillary molar, canal orifice are equidistant from a line drawn in mesiodistal direction through the pulp chamber floor. Can you see this? Yeah, can you see this picture here? Yeah, this one. Oh God, wait. Yeah. So this one and this one, right? So this is a tooth, this is a buccal aspect, this is the lingual, this is mesial, and this is distal, right? So we draw a mesiodistal line here, and it is saying that except for the maxillary molar, the canal orifices are always equidistant from the line drawn. This line, so the canals are always going to be at the equidistance, okay? Like this. So if this is here, if this is like 3 mm away from the midline, the another one should be 3 mm from the midline. Okay, so, and there is only one, then it is in, like, there is no another canal, like, you cannot find another canal here or there. Okay, you got my point? And there is another law of symmetry. Except for the maxillary molar, canal orifice lie on a perpendicular line, perpendicular to the line drawn in it. Suppose the tooth is rotated like this. Okay, you have to draw a line like this, and then you will find every, like, there is so you draw a perpendicular line, and you will always find the orifice located somewhere in this line only. Okay, you got my point? Somewhere here, here. But it should be equidistance. Okay, equidistance from the midline. Fine. If you don't understand, please drop question in the chat box. Okay. Yeah, moving forward, law of color change. The pulp chamber floor is always darker in color than the walls. You know it all. The law of orifice location. The orifice of the root canal are always located at the junction of the walls and the floor. Okay, I have like put in some good pictures, and then okay, I am not explaining much about it now. Yeah. Now moving forward, now we are done with the issues that we face during the access cavity preparation. Now moving forward, there are some troubles or issues that we face during the working length determination or while using apex locator. Okay. I just want to ask how many of you are using or have apex locator in your operatory? Hmm? See, it is very, very important. Okay. You have to know the correct apical end. Okay. What is the apical end? So, apical end is the end of the tooth where we have to limit our instrumentation on. Okay. And where we have to limit our obturating material on. And this apical end is nothing but the apical constriction or the minor constriction. Okay. Which is somewhere here. Okay. And beyond this apical constriction, the periodontium actually starts. Okay, so we don't want to violate periodontium. And can you see this picture? Can you operate? This is the apical third of the root. This is the apex of the root. Okay, and the apex that so many of us are still relying on the radiograph in the IUPA in order to determine the working length, which is like truly wrong. Okay, so can you see this? This is the apex that we are viewing in the viewing in the IUP. But can you see this is already the periodontium? Our periodontium just starts from here. So this you are actually violating the periodontium. Okay. So please make sure that you limit yourself to the apical constriction while you are doing instrumentation or while you are obturating. Okay. So how are you gonna do it? So you will find a lot of dentists out there who's gonna say, oh my God, like, in this many years of practice, I know, like, I have this tactile sensation. No, nobody has that magic in their hands. Okay. Nobody can, say that just with the help of, tactile sensation or just by seeing inside the canal, nobody can determine that, okay, this is the apical constriction. To know the accurate apical, to know the accurate position of the apical constriction, you have to use apex locator is the only device which will give you the accurate working length or the accurate position of the apical constriction. So please invest in like a good apex locator for your clinic. Okay, it is only gonna do good to you, to your patients. Okay, so please do that. And yeah, there are some issues that we face while using apex locator also. Many a times apex locator will give us like false reading. Okay, so you have to follow some protocol when you are using apex locator, like there has to be adequate isolation. It's very good if you are using apex locator under, if you are working under rubber dam, very good. Otherwise, if you don't, then at least put like pack two piece of cotton roll, like just at the sides of the area of interest, and then avoid contact with the metallic restoration. Try to use thinner file, but it should be slightly binding to the canal. Don't use very loose file also. Flush the chamber with hypo before inserting the file. Again, like too dry canal also does not give sorry, accurate result. Okay, avoid the sharp bend of the wire. Oh yeah, I'm sorry, I forgot to tell you about the so there are a lot of apex locator that are present in the market, but this is the like normal commonly found ones. So I just want to want to make you familiar with the like the parts of the apex locator. So this is the monitor, and this is the lip clip which gets clipped on the patient's lip, and this is the file holder which has a small knob like structure which is used to hold the file which is supposed to get go inside the canal. Okay, so when this the hook is lipped on the patient's lip, and when the file inside the tooth canal is clipped with the file this file clipper, the circuit is going to get completed. Okay, and that's how you work on that. So I thought I would put a video of of using apex locator, but I'm really sorry, I forgot to do that. And also, one tip I would like to give you all is just avoid buying two-in-one apex locator. This is my personal take again. Okay, there are so many, even good brands have started, have started producing endomotor or apex locator along with the endomotor along with the apex locator, but I don't personally like it. I prefer to use the endomotor without any other functions attached to it, and then separate apex locator. Okay, yeah, that's it, that's about it. Yeah, now we are moving forward on to next procedure, that is shaping and cleaning. So the troubles that we face during shaping and cleaning. Okay, so there are so many challenging cases in our day-to-day practice we find, right? Like curved canals, C-shaped canals, entomolaris case, dilaceration. When we do not do it nicely, when we do not follow the protocol, certain protocols, and when we fail to properly shape these kind of cases, we end up facing problems like ledge formation, transportation, perforation, canal blockage, which eventually lead to loss of length, working length, zipping, stripping, over preparation, instrument separation, the horror for all the dentists out there, right? So I'm going to talk about, I'm not going to talk a lot on like how we are going to tackle such cases like curved canals, because Dr. Malika in yesterday's presentation, she beautifully have already explained about how to go about it, when it comes to complex anatomies. So I'm not going to go in very much detail about it. I'm just going to give you very certain tips and tricks on these cases, but I'm going to focus on more of the issues part, and I'm going to talk about how you can prevent them and how you can solve them if at all it happens. Okay, so this is one of my cases of the management of the curved canal. See, when it comes to management of the single plane, okay, single plane curved canal, it seems quite easy to tackle with, but when it comes to multiplanar curved canal, it is quite challenging. Okay, so for this I'm only going to give you a very small tip. Like, there is a term called tactile control activation. Okay, what you can, at first, like even when you are using hand file in such kind of cases, please always you always have a have you make this habit to pre-curve. You use the smallest number file, and smallest number file is not a 15 number or 20 number file. Please be very very clear about it. Okay, always use 6 number or at least 8 number file, pre-curve it in the end, and then you insert and you use it in the watch winding motion like this. Okay, do not like force the instrument inside the canal. Okay, so you do that, and then you will and you will know that, especially with the reamer. Okay, the first file I prefer to use when I'm inserting the file inside the canal is the small number reamer, in order to see like whether it has recorded. Okay, the reamer has a tendency to record the angulation or the curvature of the root or the root canal anatomy. Okay, so that's how you're gonna prepare after that. And because again we are seeing on the 2D IOPA image, so you will only get to see the mesiodistal curvature, you are not going to see the buccolingual curvature, right? So that's how you're going to record the angulation or the curvature that is that the your root canal has, and then it will get recorded in your file, and then that's how you're going to prepare your canal. Okay, and yeah, after that there is this term called tactile control activation. So in this, what you are supposed to do is you just like the very small number rotary file I'm talking about. Okay, with a small number or the path glider file. Nowadays you get like 10 number 2% path glide, right? This path glide files, right? So what you can do is you can just like pre-curve a bit in the apical end. You take it till the area where it is passively seated on. Okay, passively resisted area में थोड़ा सा वहां तक डालने का. Then उसके बाद you can activate the endomotor. Just go like few millimeters, just 1 millimeter apically, and then you retract it. Okay, after that, when you know like when you place the hand file or any other file, it will go passively, like it will get resistant passively, but it will go little further, 1 to 2 millimeter further than how it was before. So this is the procedure what you're gonna like repeat till you reach the root end, and that is how you're gonna tackle with such kind of cases. Okay, so this is the C-shaped canal that this is one of my cases again. So you see, I'm sure like you are aware of the danger zone and okay. So I'm sure you are aware of the danger zone and the safe zone of the root. Okay, okay. I'm just gonna make it for you here. So this is a okay. I'm really sorry for the bad drawing here. And yeah. Okay, so I'm just gonna focus on this root. Fine. So this is the root canal system. This is the canal. So the inner part of the curvature. Can you see the curvature that is there? So this area is called danger zone, and this area is called the safe zone. Okay, and we are supposed to file. We are supposed to do the instrumentation towards the outer wall of the towards the outer wall or towards the safe side of the root. Okay, and the similar tip will go follow should be followed for the C-shaped canal also. Like can you see here, this is considered to be the safe zone and this is considered to be the danger zone. Okay, danger zone, it is considered as danger zone because there is very little amount of radicular dentin that is present as compared to the outer wall. Okay, that is the reason why we call the danger zone the inner part of the curvature. Okay. And in the C-shaped canal, since it is like we have to do, you have to follow the circumferential filing and then do more of the filing towards the outer wall of the canal. Okay, that's all I want to give yeah, speak about it. Sorry. Now let's move forward onto the problem that we get if we do not treat these complicated cases, these challenging cases nicely. Okay. Um, yeah. So these are the issues that we can face during the shaping of the canal. The main like one of the main problem is the ledge formation. So ledge is nothing but the shelf-like structure that is happening. Can you see in this picture? So there is a shelf-like structure which is happening in the outer wall of the root canal system. Okay, which will prevent the other instrument to go in its actual original canal path. Okay, so when you make a ledge, then it is just it seems just impossible to insert your actual file in the actual canal. Fine, so what do we do here? So for the first thing, please try to prevent. Okay, try just like make a point not to make a ledge in this. So and for the prevention, I have jotted down some point for you all. You use a small number file while you are treating such cases or any case, and specifically like such complicated cases. When you are dealing with these challenging cases, you start with the using of the small number files. Again, pre-curve and use in the watch winding motion. Okay, read the canal angulation well with the help of radiograph. Okay, the small number files are supposed to be used before inserting the rotary instrument. Oh, I have a great incident that I want to share with you regarding this one. And then avoid jumping the step in rotary file system also. See, let's say in the dense ply prototype system, there is like SX, S1, S2, F1, right? You cannot, even if the canal seem very much open and wide, please do not jump. Even if you are very much sure that okay, as I have prepared till S1, I'm gonna go for F1, please don't. Okay, mishap will happen. Mishap actually happens due to such hurry. Okay, so always follow the steps of the file system according to manufacturer's instruction. Okay, always follow the manufacturer's instruction. And the thing I was telling you about the small file numbers before inserting the rotary instrument, like I have done this. Okay, what I have done was, one of the patient came to my operatory. The patient was referred to me, and when I took the IUPA, it was a case of 1/6. Okay, our root canal treatment had to be done, and then when I took the IOPA, even with the angulation, it was looking very much okay. Okay, it was the mesial and the distal, the mesiobuccal and the distobuccal root were looking very straight. The parietal root, as always, it was looking very straight. Even the canals were very straight, and I was very good to go about it. Okay, when I did the access opening preparation, access cavity preparation, I could see like big, big three like orifices there, and I was very happy. Usually what happens is, like, we know that the when we are inserting file on the parietal root. Okay, I just want you to imagine, I'm really sorry I don't have like good pictures here, so I just want you to imagine, while you are working on 1/6 or 2/6 for in the parietal canal, you always insert the file from the buccal towards parietal, right? And for the distobuccal root, you always try to insert file from the mesial or mesioparietal, from mesioparietal direction towards the distal, right? And usually for the mesiobuccal root, you usually put the file straight, right? It is usually straight, okay? And that's where I mistook, okay? That's where I did blunder on. So I just put, directly, like, even without, because I saw a proper, like orifice, I thought it was a very big, canal inside there. So I thought I didn't need to, know the anatomy, like how it was, the inclination of the root or whatsoever. Then what I did was I directly put orifice opener in rotary, okay? With the rotary, I just put orifice opener in the mesiobuccal, like putting it directly, because the patient, the tooth was very much upright and very much like, in the occlusal plane and everything. So I put like in the 90 degree, like just like straight along the, I thought the mesiobuccal root was very much straight, and then I straight away put the, and then while I took it out, I could not see the tip of my instrument, and that's where I knew that I did a blunder. And then I sent patient for the CBCT. When I saw the CBCT, to my shock, the mesiobuccal root was very much inclined, very much angulated, but it was angulated in a buccal. Like, it was angulated buccally, okay, which is like, no way it was possible to be, seen in the IOPA, okay, because I have already taken like three directional X-ray, three angulated X-ray, and I couldn't find any difference in any, okay, because again we are looking at the 2D X-ray, which is only gonna give you a brief idea about the mesial and the distal angulation, and not about the parietal lingual or the buccal inclination, right? So yeah, and that is when, so one tip I would like to give you all is that once you prepare the access cavity preparation, once you do the access cavity preparation, even though no matter like how, good your X-ray is, like, how straight your root looks in the IOPA, you always put the first file that you put is hand file, at least to learn about the inclination or the angulation of the root that is present there, okay? The root might look very straight in the IOPA, but it may be, very much palatably or buccally angulated, okay? So after you like put the file, you just leave, and then you see, okay, like in which direction it is going on, and then you follow the same direction with the rotary files, okay? So yeah, so these are the prevention part, preventive measure for the ledge formation. So if at all the ledge happens, how are you gonna tackle with it? See, as you can see in this picture, the ledge usually happens in the outer wall of the canal wall. Okay, so for this, what you can do is, can you see the red dotted line here? You can just flare. Okay, you can give a coronal flare on the outer wall till the ledge has happened. Okay, it will give you a straight line access to the towards the original canal path. Okay, are you getting my point? So like if you open this area, your file will go from here, right? Oh God. Yeah. So if you like flare this area, you can like insert your file from here, and it will, there are higher chances of getting your file in the normal anatomy, right? And yeah, this is what you can do. You have to flare the Just a second. Huh? Yeah. So you can give a good coronal flare on the outer wall of the ledge, and again with the help of like GG drill or a micro opener or ultrasonic tip also will be of great help in order to get straight line access to the original canal anatomy till the apex. Okay, and please use small number file. Again I'm saying use small number file, pre-curve them, and then use it in a if you are using the hand file, use it in a watch winding motion. If at all you are using the path glide files with the rotary system, you put it in a very low RPM, rotation per minute. You keep it till like 200 RPM, okay? And I have mentioned here, if you are using this, what do you say? Um, if you are using the rotary instrument, you have to follow this RRR manner, okay? It is not RRR movie that I'm talking about. This is something that I have, created for your ease and to make you understand well. So whenever, like after you put the pre-curved file inside the canal, whenever the resistance is felt, whenever the first R is felt, you retract it a few millimeter, you slightly rotate, and then you again reinsert it. Okay, and then there will be one point when the the file will take go into the actual canal anatomy. Okay, original canal that is there beyond the ledge, and that is how you're gonna yeah troubleshoot this issue. Now, another problem that we face during shaping is perforation. Again, prevention is the key. In order for you not to create perforation or like ledge formation, you have to follow the law of orifice, use the right drill or burrs, and use of always follow the anatomy of the tooth, always follow the axis of the tooth. So yeah, you have to read the anatomy of the root and tooth within the x-ray also clinically, and that's how you can prevent yourself from perforating the tooth. Okay, so if at all it happens, how you can troubleshoot this issue? At first you have to identify the perforation, okay, with the help of either you can use apex locator or with the paper point. Many a times what happens is, even if you have perforated the floor or tooth anyway, you will think that okay, no, I think I have I'm still in the orifice, and you will start and that is where apex locator is of great help. Okay, like at times even x-ray might not show you that you have perforated it. Okay, it looks like you are going in the canal itself. Okay, but like as I have mentioned before also, the moment you touch the periodontium means like even the gingiva or the periodontal ligament, if you reach that area, the apex locator will show you that you are out of the apex. Okay, and that is how it is going to help you in identifying the perforation. Okay, so always keep your apex locator at your at your working desk. Okay, and with the paper point also we'll be able to figure out where the perforation is. And if at all there is a focal perforation, at first you identify it, again with the help of apex locator or paper point. You control the bleeding with the help of hemostat, and then you try to seal it ASAP, as soon as possible, with the help of bioceramic or MTA based cement. Okay, it's better that way. And relocate the orifice and negotiate the original canal. Okay, also please beware of the sodium hypochlorite extrusion in such kind of cases, and that is the reason why I have been telling you that please seal as soon as you see the perforation, just seal it as soon as possible. Okay, if the perforation is happening in the middle part of the root, use bioceramic or MTA based cement. Okay, you just apply it at the area. Again, it is like magnification is of great help in such kind of cases. And again, as I said before also, as I mentioned before also, you cannot work if you cannot see. Okay, so you under the magnification, you put the bioceramic cement or MTA based cement or MTA inside the canal, and you go for shepherding technique. Okay, shepherding technique, what you do is, once you put the cement inside, see, it is very difficult like to find out, okay, there is the perforation, and we are not able to like see the perforation directly, and not it is very no, it is not very easy. Okay, So in the shepherding technique, what we do is, once we place the cement inside the canal, we just activate the irrigation device, irrigating device. Dr. Anu, a day before yesterday, she mentioned beautifully about the irrigation device also, like ultrasonic irrigation device, right? So you use a thin tip, you place inside the canal, and then after the after you place the cement inside the canal, you just activate it, okay? And then after the activation, the MTA or biceramic based cement is gonna get settled in the perforated or resorbed area. Okay, and after that you can negotiate the actual canal and directly obturate the canal. Okay, if at all the perforation is happening just above the crystal bone, but it is not visibly visible clinically, you can raise the flap and seal the perforation with the help of MTA or biodentine. Okay. So there is this another issue that we can face during the shaping of the canal, which is canal blockage. And due to the canal blockage, you will lose the working length that you were working on before. Okay, and usually this canal blockage is happening because of the dentinal debris that has gotten accumulated in the apical end. Okay, and why is this happening? Because you are like you are directly, when you directly use like large number of files, when you like do instrumentation, hand filing, and instrumentation in a pushing motion. Okay, don't be very aggressive, you be very very gentle when you're using the hand files. And even with the rotary also, the instrument will itself take you through the anatomy. You don't have to force any instrument when you are inside the canal. Okay, so yeah, that's when it happens. Okay, how do we prevent it? As I said before, also start with the small number file. Do not, and the small number file is not 15 number file. Okay, no matter how wide it looks in the IOPA, please don't go with that. Okay, you just start using a small number file, and copious irrigation with the sodium hypochlorite and saline is of great help. Okay, uh, and recapitulate the canal with small number file in between the instrumentation. Yeah, this is one another thing. Like we are just constantly doing instrumentation, like okay, this file, the big number file, and then like we go sequentially like that, right? But then we forget to recapitulate, we forget to in order to maintain the patency of the canal, you have to like you have to have this recapitulation happening in between the instrumentation. Okay, and also like when we are doing instrumentation, there are a lot of dentinal debris that are going to be there, right? And above that, if you are pushing the instrument over that without recapitulating, there are higher chances of getting the canal blockage. Okay, and again like eventually losing the working length. Okay, so that is the reason why you have to recapitulate the canal with a small number file, along with the copious irrigation with the saline or hypochlorite. And do not shape the canal in pushing motion, like I mentioned before also, right? Now trouble, how if at all it happens, first of all, please make sure that this does not happen by following all these measures. If at all it happens, how do you troubleshoot this issue? You use EDTA solution. Okay, like Dr. Anu really nicely mentioned the other day also, you are not, don't like, if not necessary, if it is not calcification or anything, do not use EDTA gel. Okay, go with the 17% EDTA solution. You just like irrigate the like the canal with that. Use a small number file in watch winding motion. Again, please do not push, do not use files in the pushing motion. Okay, and once the patency is regained, okay, once the patency is regained, just flush the debris out with the help of sodium hypochlorite and saline. Also, activation of the irrigant with the ultrasonic tip is going to be of great help. Okay, and again, as I said before, also avoid forcing the file through the black blockage too. Okay, now, the nightmare of all the dentists, okay, instrument separation. Nobody wants to, nobody, still like it's been like just 3 4 years of my dental practice that I have, and whenever I still separate the instrument, okay, and I'm saying it with a lot of guilt in my heart, but no shame at all. Okay, so I have done this also, and I will, end up in the same situation in later like in future also. Okay, but just but now I have knowledge, I have brief knowledge on to, okay, like it's always better to prevent things from prevent such issues from happening. And yeah, if, even if at all, like, it's a huge topic again. Okay, it's a very very huge topic, and I have actually summarized it a bit for you people. And yeah, so yeah, so I've mentioned like what are the common causes that can cause instrument separation. Okay, so the common causes are like improper use of the file, inadequate access. So that is the reason why, see, there it's a very controversial thing to say, but then there are, you know, things like this ninja access these days, right? Everything is, you know, what do I say, like everything is like justifiable. Okay, everything can be justified. In the, like other patients also, only if you have the knowledge about the metallurgy of the instrument that am I audible, everyone? I think I lost my connection. Am I audible?
Yes, ma'am.
Okay, okay. Sorry, I think just give me 2 minutes. Just give me 1 minute. Okay, just give me 1 minute. Mm. I'm sorry, everyone. I'm really sorry. Um, yes. Okay. Yeah. So I was talking about the common causes that cause instrument separation. Common causes, they include the improper use of the instrument, inadequate access, and yeah, like I was talking about this ninja access and everything, right? Everything is justifiable, but if you are using the right armamentarium and device and the burrs and everything, okay, and yeah, so if the root canal anatomy is curved, and possible manufacturing defects can also be there if you are unfortunate. Night eye files are said to be, you know, more prone to fracture, absence of the glide path, okay, skipping steps in the file system, and not following the manufacturer's instruction can lead you all to instrument separation. Okay, so you should know when to discard a file. When it comes to hand file, you just see for kings or, you know, loss of flutes will be there, the dull flutes will be there. So that is when you will get to know that, okay, I need to discard this file. Okay, and when it comes to heat treated night eye files like the rotary files, you have to see, usually it goes unnoticed. Okay, so please try to limit the, you know, usage of file in like limited cases. Like I know like it is not suggested, so but like you try to limit the usage of such files in like 2 to 3 cases you are done, and then I think you should, you know, discard the file, which will help you to get rid of instrument separation. Okay, and again, like many a times it will also, like sometimes it also shows that, you know, like too much of cyclic fatigue and torsional fatigue in the night eye files will end up getting the night eye files with the unwinded flutes and open flutes, and increased file length will be there. Since there is opening of the flutes, the file length will increase. So in that case also, just like discard these files and start using the new ones. Okay, so yeah, main thing is you have to address the problem, and then you have to see it accordingly. So that's how you're going to prevent the instrument separation from happening. If at all it happens, okay, how you are going to troubleshoot this issue. So again, one should know when to discard the file. There are a lot of, like mechanical chemical and surgical ways to remove the separated instrument from the canal. But and I have like just made a small table for you all to have a like like little bit of idea, so as to how to make use of ultrasonic tips and the GG drill when it comes to the separated instrument. You see, if the instrument separation is above orifice, okay, there may be a lot of other ways also. Okay, these are just my take on how I deal with the separated instrument cases. So if the instrument separation is just above the orifice, you can use hemostat or a forceps or tweezer or needle holder for that matter to take out the instrument which is above the orifice. You can use braiding technique also, and in which you just bypass the you just like insert like 2 3 small files, and then you just wind the file around that separated instrument, and you just like take it out. Okay, a spoon excavator is of great use. And if the instrument separation is below the orifice, what you can do is you expose the coronal 2 mm of the separated files. First you have to come, first you have to make a stage platform. Okay, I'll just help you with this. Yeah, if this is the canal route, if this is the canal, if this is yeah, the separated instrument. Okay, this is a separate. You have to widen the core. You have to do the coronal flare. That is that you are making a stage platform here. Okay, so you are making a stage platform till this point. Okay, and after that, after that, what you're gonna do is like you will trough the area around that coronal portion of the instrument, either with the help of ultrasonic tips, or there are a lot of system that comes with the trephine burr. Okay, so trephine burr is gonna like help you with the troughing of the coronal portion. Okay, it is gonna trough the dentinal portion around the at least like 2 mm of the coronal portion of the separated instrument. Okay, so and after that you can like use the ultrasonic tip activating this separated instrument in the counterclockwise direction, and it will eventually pop out of the orifice. Okay, if Yeah, sorry. So if at all the separated instrument is in the curvature, make a staging platform. And okay, as you can see, this is for the picture is for the separated instrument, which has happened like just below the curvature or in the curvature area. Okay, so you have to make staging platform till here. Okay, and you have to like with the help of modified GG drill or again large number rotary files also. Okay, you can make a stage like that. And then what you can do is you can just insert a like small number, or you can insert one ultrasonic tip, and you can start activating. No, at first you have to trough the dentin around the coronal portion of the separated instrument. Okay, after you see the like coronal like 2 mm of the instrument, what you can do is you can just insert one ultrasonic tip in the inner aspect of the, can you see this, in the inner aspect of the canal wall. I've mentioned this before, like you can like it's better if you are doing filing or instrumentation on the outer wall of the outer wall of the canal wall, because like it is a safe zone, right? But यहाँ पे ulta we are doing it in the inner wall, right? Obviously there are high chances of getting the like perforation and everything, but again that is the reason why we are using the small like thin ultrasonic tip in this kind of cases. And it is said that activation, if you are activating the file on the outer wall canal curvature, it redirects the separated instrument even more apically. Okay, so it is always advisable to activate the instrument from in the inner curvature. Okay, in the inner curvature canal curvature, which will redirect the separated instrument in the coronal aspect of the canal. Okay, So like many a times it won't like come out of the orifice itself, even though like even like while you are seeing the instrument, separated instrument dancing inside the canal, like you won't be able to take it out just like that, right? So in that kind of cases you can use microtube technique, or the loops also is going to be of great help in those kind of cases. Okay. Yeah. Now I'm going to talk about the issues that we face with the while irrigation, while cleaning. Okay. And this is another nightmare, another horror for all the dentists out there, the hypo accident. Okay. It is usually caused due to the inaccurate working length that we have determined, due to the iatrogenic widening of the apical foramen, due to the due to the lateral perforation, iatrogenic perforation, or the pathological resorption or perforation that was already there. And when there is it is also caused when there is wedging of the irrigating needle. Okay. So for all, because of all these reasons, there will be hypo accident. Okay. How are we going to troubleshoot this? Again, prevention is the key. And how are you going to prevent this from happening? You have to establish the correct working length. And how are we going to do it? We are going to do it with the help of apex locator. Again, if you again, like, can you imagine you are looking at the radiographical apex and you have determined that okay, this is the root tip, this is going to be my working length, but you are already going out of the apex. Okay, the apical constriction is about like 2 to 3 millimeters short of the radiographic apex that you are seeing in the x-ray, in the 2D image, right? So in that manner, what will you end up doing? You are actually extruding, while you are irrigating the inside the canal, you are extruding the irrigant outside the in the periapical region, right? Which is not acceptable. So that is the reason why I asked you to invest in a good apex locator, so that you get to establish a correct accurate working length, and then you like save yourself from this all mishaps happening. Okay. Then proper isolation is gonna be of great help. Use rubber dam, and pre-endo build up. Use side vented needle with this stopper, as Dr. Anu also mentioned in her in her this thing in her lecture. See, I'm gonna just can you see in this? See, I've just brought this. Okay, so this is a side vented 30 gauge needle. Okay, and then how you gonna do it? As like if the working length is suppose 16 mm. Okay, you should like keep your, yeah, like this, and you can just bend it like this, and this is the 16 mm. Okay, suppose if the like you have to keep this like almost 1 mm short of the working length. Okay, so this is how you're going to work on a 17 mm like a working length uh, tooth. Okay, did you get my point? Like this. Hmm. Yeah. So that is there. And again, irrigation with the palm rest. Yeah, this is one thing that I really want to tell you all. Like usually what we have tendency to do is we inject the this irrigants inside the canal like this, right? With the finger. It's always advisable to use your palm. Okay, this gives you like more stability. See, smallest of things, they make the greatest impact in your life. Okay, similar like this also, it may seem like it's a very small tip, but you really need to follow, and this is going to change your life for sure. It has changed mine. Okay, so like better than this one, it's good if you are like pushing the, or irrigating the canal with the like palm rest, okay, on the barrel of the syringe. And also it's better, like all these things are all these like irrigating technique is the positive pressure one. There are like beautiful systems named like endovac system, in which negative pressure is being used for irrigation. Okay, so yeah, prevention is the key, and this is all the preventive measure that you can go with. And if at all it happens, if at all the hypo accident has happened, if at all it has you know spilled on the oral mucosa, it will cause chemical burn. What you will do? The first and foremost thing you can do is to dilute the irrigant. Okay, so either you ask patient to rinse their mouth, or you can just rinse the area with the saline or water. You give analgesic to patient and just ask patient, like, and then give cold compresses to the patient, so that it will just give some soothing effect or comfort to the patient, right? And if at all it gets extruded in the periradicular area, you again give anesthesia, analgesics, and cold compress and antibiotic, corticosteroid for the pain control, and moderate for the moderate swelling and edema. Also, you can give this medication. Irrigate the canal, irrigate the canal with saline. Okay, and use endoaspirator to reduce the effect of the irrigant. Okay, so you're gonna dilute the, you are gonna dilute the irrigant that is already extruded with the help of saline, and use endoaspirator. So there is a very good device also, like invest in this particular thing. Okay, endoaspirator is a great great device, like to aspirate the liquid or any irrigant out of the canal, like through the suction in our operatory. Okay, so you can do that. So it is going to help you to reduce the effect of the irrigant. And then after that, like you can give some cold compress also to patient for a while, and you ask patient to get the warm compresses and warm oral rinse after 1 day, to which will stimulate microcirculation, which is ultimately going to help the patient in the healing phase. Okay, if the case is very very severe, just hospitalize the patient. Okay. Now moving forward, now we are done with the trouble that we face during the shaping and cleaning aspect. Now let's move forward to the issues that we face during the obturating phase. Okay, obturation. So the first thing is crimped GP. So do you like remember the curled up GP that happens in the apical end? While we are taking the master cone GP, we're gonna take the X-ray. It is coming short, and then not even shortly, it will look like this. But then when you are talking taking out the GP, it is slightly crimped at the end, or it is slightly curled up, right? So this actually happens when the preparation is large and the GP is of small size. Okay, so yeah, so you try to use or you try to use the GP, or and again, this is for the cold lateral condensation. If you are using thermoplasticized technique of obturation, then you are good to go. Okay, but like for the cold lateral condensation, you please try to match the preparation, and then you use the same number GP, or like accordingly you can put the GP in the canal. Obturation in the open apex case is quite challenging. I have just mentioned here, like you have to, the MTA, you have to plug MTA in the apical end for such kind of cases. If at all, if you want to, if at all, if you want to obturate it with the help of the GP itself, you can always go for the roll cone or customized cone technique. So there are like a lot of videos in the YouTube how you customize the GP according to the according to make it fit, like fit for that like open apex case. So you can do that, but it is more advised, it is advisable for you to plug MTA in that area. So for that, for the MTA, in many of such cases there is bony cavity due to the bony resorption that is happening beyond in the periradicular region. So in that case, what happens is MTA is, there is a high tendency that you can extrude the MTA or any material in the bony cavity itself, and it is only gonna get give discomfort to the patient. So in order to prevent that from happening, what you can do is you can just like make a apical plug. Okay, apical plug as an apical matrix to hold the MTA on. Okay, so it can be like a lot of things are there for that. You can use PRF also, and you can use even there are there are case report which says that they have used resorbable suture also. Okay, in order to make a apical matrix, like in order to hold MTA in place. Okay, so after that you can place MTA, you can plug MTA in the apical end, and after that either you just like fully you can obturate the canal with the help of MTA, or after that you can just use the thermoplasticized obturation technique after that. Okay, Another problem that we are facing during the obturation is radicular extrusion of the root canal material, okay, which is not acceptable at all, which I'm going to talk in brief in the later slide. And another problem that we face is inability to place spreader or plugger. Many a times, क्या होता है, like after we have prepared and then we have done the obturation or master cone GP we have taken and then done, and then we have taken an IOPA, okay, we can see so many of dead space there, okay, but there is no space to put your spreader or plugger on, right? So उस time पे क्या करना है, like you can just flare the coronal part a bit and then like it will be easy for you to put the spreader and then the further accessory cone inside the canal. Okay, so that is the only tip that I want to give you on this particular slide. Yeah. Now talking about this major problem that we face during the obturation phase, that is radicular extrusion of the root canal material. Okay. So if at all, like the prevention is actually the key here. Okay. But if at all it happens, what like, it is gonna cause post-treatment inflammation and pain. Flare up is gonna be there. There will be delayed or lack of periradicular healing. Okay. And there are many causes of extrusion, like because due to the lack of material control, specifically in the over prepared tooth, and if we are using a thermoplasticized obturation technique, so we lose control with the material, and due to the lack of material control, there is extrusion happening like in the periradicular region. Again, like I mentioned before, accidental over instrumentation is going to cause extrusion, incorrect working length determination, and especially in the retreatment cases where like a lot of push and pull filing strokes is happening, in these cases also there is extrusion, there are chances of getting the extrusion happening. Okay, how are we going to manage it surgically? Just like raise your flap and then surgically remove the extruded material. Okay, but non-surgically what you can do is there are like a lot of these non-surgical methods like use of heat carrying instrument, and ultrasonic tip is of great help. Solvents you can use, rotary and hand files also are of great use. Okay, so like there are some kind of tissue damage that has happened because of the radicular extrusion of the obturating material. And how are we going to manage this damaged tissue? We're going to give analgesic to the patient, cold packs, corticosteroid, antibiotics. Okay, if the case is just out of hand and it is seem unmanageable to you, just hospitalize the patient and then take care of it in a systemic manner. Okay, now let's talk about the inferior alveolar nerve injury. Okay, there are many cases which has been reported. Okay, that reported of the inferior alveolar nerve injury. See, this should not have happened. Okay, this just should not happen at all. Okay, so like there are many causes of inferior alveolar nerve injury. Like surgically, when we are opening the flap, when we are giving the incision, we might wound the nerve, or we may cause injury to nerve with the scalpel blade. Okay, so please make sure that you are giving incision on in the right anatomy. Just like make a good, like read about the landmarks, and then you know make the incisions accordingly. Okay, and non-surgical causes of the inferior alveolar nerve injury is the chemical extrusion. Okay, chemical extrusion like cytotoxic material, like anything that is going inside the inferior nerve is bad. Okay, so like that is the reason why I've been telling you, like you have to be very accurate with your working length. You cannot afford you cannot afford like anything going beyond your this thing, beyond your apical foramen. Okay, not even in the vicinity of the mandibular canal, not even in the vicinity of the inferior alveolar nerve injury, I mean inferior alveolar nerve. Okay, so there are some other mechanical cause also, even the repeated instrumentation. When you are not when you are not determining the working length accurately, you may end up over instrumenting, you may end up doing over instrumentation in the canal, and then you may end up injure the inferior alveolar nerve that is just below the mandibular canal, I mean mandibular tooth, right? So please avoid that. And thermal, again, like while we are when it is when the heat application of 10 if the when the heat application of more than 10 degrees centigrade is there, even in the vicinity of the inferior alveolar nerve, it is going to cause some or the other like injury to the nerve. So management is, again, prevention is the key. Okay, you please make sure that you are not pushing anything or going, pushing anything beyond the beyond the apical foramen. For that reason, you have to limit yourself in the canal or the apical foramen, okay, with the help of apex locator. You just do that. And then another thing is, if it all it happens, you have to, like, if it all, like, this injury happens, if it all the extrusion is happened, or the, any of these things have happened in the inferior alveolar nerve, what you gotta do is you immediately remove the irritant. If extrusion, okay, you gotta immediately remove the irritant, okay. And the prognosis of this injury depends on the severity of the direct injury to nerve, toxicity of the irritant, and how rapidly the irritant is removed, okay. Like, the faster you have removed the irritant, like, better will be the prognosis. All right. Now, this is there is another thing. This is cervicofacial subcutaneous emphysema. This is nothing but the penetration of the air or gases underneath the skin or submucosa, which results in the soft tissue swelling, soft tissue distension, airway compromise, and soft tissue infection. Okay, so why is it being how can you get emphysema? Okay, even in the simple cases, okay, even like we have a habit, okay, if, like, for those who are not using isolation with the rubber dam, for those, like, the, like, the tooth, like, when after you are done with the access cavity preparation, it is all flooded with the saliva. You need to sweep properly. So what we have tendency to do is you take out the three-way syringe, and you just, like, press the air compressed air through the air syringe, right, which is one of the major causing the emphysema. Okay, so it's better if you use rubber dam. Okay, I'm gonna talk about the prevention part. So let me first discuss about the causes. So compressed air through the air syringe, high speed handpiece is also going to cause emphysema. Use of dental laser, hydrogen peroxide beyond the canal space is also going to cause emphysema. Lack of rubber dam isolation. Okay. Again, prevention part, avoid using hydrogen peroxide as irrigant, use rubber dam isolation, minimize the use of high speed handpiece, okay, and start using the rear exhausting high speed handpiece are also there, so you can use that, okay. Mm. Now, yeah, now we are done with the issues that we face during the obturating phase. Now, yeah, if we are not able to, like, troubleshoot those problems, if we are at all we are not able to, solve the problem, that issues that has been there, like, till intraoperative issues, intraoperative phase, we are gonna face this problem, okay, like persistent pain and swelling is gonna be there, and root fractures due to the, like, too much of occlusal load is gonna be there, okay. So yeah, so for this reason, for this thing not to happen with you, you have to properly take care of the mishaps or issues that has happened before this, okay. So yeah, so I'm almost done with my presentation. I'm just gonna, like, give a more emphasis on the preventive strategies. See, you can, like, it is always good. It is always good if you are very much far from all these issues and problems, and it is only gonna be, it is only gonna happen if you are taking preventive strategy seriously, okay. So preventive strategy has nothing major, but the use of magnification and illumination, the pre-treatment planning has to be made nicely, the adequate isolation, and you have to follow proper technique with the right instruments, okay. Yeah, that's all I want to say. So these are some of my cases that I really wanted to showcase to you. So this is a case of C-shaped canal, where, like, when you are seeing in the IOPA here, it looks like, perforation. So, like, in order to, check whether it is going in, like, whether it is perforation or either it is actually going inside the canal, you can always confirm it or identify the this thing with the help of apex locator, as I mentioned before also. This is the torodont. Again, please make sure you are using magnification. So in this one, the separated instrument has been retrieved with the help of braiding technique. And in this, the microtube technique has been a great help. And radix intermolaris. Yeah. So yes, these are some of my cases that I really wanted to show. Now, this is the final tips and takeaways that I want to tell you. Again, prevention is the primary management key. Do pre-treatment planning, proper pre-treatment planning, like do proper clinical examination along with the radiographical analysis before you make any diagnosis or treatment plan. There is a great help of magnification with good illumination in your practice. So please start using magnification with good illumination. Use like start using rubber dam isolation. Use right instruments and techniques. And even if the mishaps happen, and mishaps do happen, even like still, with so many great endodontists out there, they also face mishaps. But stay calm, okay? Stay calm. If at all you have the right knowledge, right technique to do, to correct that, you do that, or else you can always take experts opinion or their help for that, right? Now, I would like to conclude my presentation by quoting this by amazing quote by Dr. APJ Abdul Kalam. Man needs his difficulties because they are necessary to enjoy the success. Okay, so even if the mishaps happen, don't worry. Okay, don't worry. Just calm yourself down. With the right training, technique, and technologies, with these three T's in your dentistry life, mishaps can be very well taken care of. So, with this, I would like to sign off for today's lecture. Thank you so much, everyone. Thank you so much for listening to me and for being there with me all this while. I know it was not a very small topic to cover, but then I've tried to like compiled it in one space, and then like tried to make it as clinical as possible for you guys to understand. So yeah, thank you so much, Dr. Vishaka.
Thank you so much, ma'am, for sharing this informative and engaging lecture with us. And we have actually few questions with us. So if you could please answer them.
Okay, can't see. Mm.
Should I read out?
Yes, yes, yes.
Okay. There's a first question by Gulfam Ali. He's asking that whether Artican can be used with epinephrine or what?
Yes, yes. It is with
Okay.
epinephrine. It is with 1 is to like 100,000 concentration epinephrine. Yeah, it is like that. Like commercially, it comes like that only.
Okay.
Mm.
And the next question is by Dr. Akash Chauhan. What magnification to buy and brand for loops?
Okay. See, I'm not gonna specify. There are a lot of brands, but then please again don't go for cheaper ones. Okay, there are so many brands like Kalgis is there, Heinz is there, Kiehl's is there, and then I am personally using Ergonoptics. Okay, it is very nice. I find Ergonoptics a very reasonably good. It's affordable also, and it's nice. If at all, if you want to start with the loops, you can start with 3x magnification. Okay, and like eventually you can go towards like 4.5x or 5x for that matter. So these are the brands that I would like to list out. But then don't go for like cheaper ones, okay? Because you may think that, okay, I'm investing in some loops, but then again, your vision is very precious. Okay, your vision, your eyes are very precious. So like for you, just think that I have been using the same loop since like seven years now. So it's worked very well for me. So it's just like one time investment, and it does wonder to you to your practice and to patients also. So yeah.
Okay, ma'am. And there's a next one by Dr. James.
Mhm.
In cases of persistent post-treatment disease, despite radiographically and clinically adequate endodontic treatment, how do you differentiate between a true endodontic failure and an extraradicular infection, as in like ectonomycosis? And next is what advanced diagnostic techniques or treatment modification would you recommend?
Um, Post treatment, like as in like re-RCT cases, are you trying to say, Dr. James? Clinically adequate. See, go for a CBCT. Okay, go for a CBCT. If at all, I think I'm getting the question correct between a true endodontic failure and an extraradicular infection. An extraradicular infection is a endodontic failure only. Uh, See, you make sure that you are, following the proper protocol right from the access opening till the, obturation. And in a bigger like radicular infection, if at all like you are not able to achieve the dry canal, the like before obturating, it's better if you go for for episectomy or like enucleation of the periradicular infection or lesion surgically. Okay, so that is one point. And what are the diagnostic techniques? You can always go for cbct, Dr. James. You have to see the cbct first, and you can just always see if there is any missed canal, or if at all like if you have missed any. So yeah, that's all I can say. I think I have not understood the question well. I hope that helped you a bit. If not, then please like write down in chat below what you meant here.
Okay, ma'am. There's a question by Dr. Akash Chauhan. He's asking, can you please repeat how to restrict ourselves to apical constriction?
Okay, like use with the use of apex locator itself. Okay, apex locator is the only thing that is going to give you the right accurate position of the apex apical constriction. Okay, because like I mean out like above the apical constriction, you are gonna like the periodontium is gonna start. Okay, and then the apex locator is gonna tell you where you have where like where your periodontium is. Okay, so the moment it says that okay like when it gives you a mark of like you are going above apex, you just retract the file. And like basically apex locator is the one which is going to give you a correct accurate this thing accurate working length, or like give you a length till the apical constriction. So that is how you're going to do. And then after that you can just like limit your instrumentation and obturating material till that working length. So it is not about apical
Okay.
constriction, it is about the working length that you want to know, and it is only going to happen with the help of the apex locator and not with the tactile sensation or not with any other, not with the radiographical examination also.
Okay. And there's a question by Boston Dental UAE. When a separated instrument is located in the apical third of a canal, what are the best strategies to manage it? Should we always attempt retrieval, or are there cases where bypassing or leaving it in the place provides a better prognosis?
See, there is no, like there is no written thing as such, like, like, okay, leaving this is going to have a better prognosis or taking it out is giving us a better prognosis. There are many a times, like, I know many a times that, it is just impossible to take it out, okay? So at first you just, try to at least bypass it, okay? Even if you are able to bypass it and not like able to take it out, it is going to be of a great help to you, okay? Only by bypassing it, okay? Because the most critical part is your apical third, right? Only if you are able to obturate or get a good seal in the apical end, it will be easy, like your problem is half solved there, okay? So like first you try to attempt the retrieval. If not, then at least try to bypass it. And even if you're not able to bypass it, if you like, you can leave it like that. If there is a chance of getting like getting it surgically done, if you want to take it out surgically, then you can do that too. But if the patient is asymptomatic, and then leaving it in place is a good idea, I feel. Okay, so, but let the patient know, okay, let the patient know. And again, like if you are again like following the like proper protocol of sterilization of the instrument, if you are putting the sterilized instrument inside the canal, then I don't think you should be very much worried about getting the reinfection happening in such kind of cases, if at all you are leaving the instrument at the place itself.
And there's a question by Dr. Akash Chauhan again. What do we tell to patient after instrument separation? Main challenge is when he goes to some other dentist and we don't know what he might tell him.
Yeah, that is the reason why you have to always inform the patient. Okay, what I used to do is like पहले ज़माने में तो they used to use like stainless steel only to obturate. No, they used to use silver cones only to obturate it. So like in like some manner, it is obturating your canal. So you just like tell patient like that. I know it's a very like. away thing to say, but then like you can, like you have to let the patient know. You see, you have to let the patient know, but this can happen, so you can't live in fear the whole life that like he can go to other dentists, and you like he might get bashed by the patient like in some day. So like don't take that headache, just let patient know first, like try to resolve the patient like patient's issue. Or if at all, like if you can't do it, just like take experts opinion, no, you just do the referral. Okay, there are so many people with great skills and with great armamentarium in their operatory, so they can help. If at all, like they also can't, then it's almost impossible for anyone to take it out then. So yeah, I think you should let the patient know if at all this instrument separation has happened.
Mm. There's a question by Dentistry is that in Dent, post endo pain and flare ups. Despite following all the protocols, some patients still experience post endo pain or flare ups. What are the key factors that contribute to such cases, and what proactive measures can be taken to minimize these complications?
You have to like follow proper protocol. Okay, like I have mentioned, like that is what I was talking about the whole in the whole like seminar. Okay, you cannot have post-endodontic pain and flare-ups just like that. If you are following the proper protocol, the proper shaping and irrigating technique, it is not going to happen. Okay, it's our like we have the humans, we have tendency to say that okay, this is a psychological pain, patient is like this. No, if patient is saying that she or he or she is having pain, that means he or she is having pain, and it is like it is your mistake that that has led to this. Like I mentioned in the last slide, also in the post operative issue that we face after the root canal treatment, if these issues are not resolved in the first place, you are going to get such problem. Okay, and many a times post-endodontic plane, even after like you are doing everything nicely, sometimes what happens is like some amount of exudate or the debris are going to get pushed out in the periradicular region, and which will cause post-endodontic pain. So in such kind of cases, at first, when I know that I'm very sure of the fact that I have followed all the protocols and I have done a good root canal treatment in this particular patient, even after that, if the patient is coming with pain and then like at the first go, I prefer giving the patient the antihistaminics, okay, to take care of the irritation that has been caused by the extrusion of the debris from inside the canal. And then I see, I check it for some other day, and if it doesn't help, then I would prefer for the re-root canal treatment, not just leave patient like that.
There's a question by Dr. Shibika. Sometimes during re-RCT in large apical foramen cases, hypo seeps out and causes an ecchymosis like lesions. How to do counseling to patients and how to avoid even with good measurements? Sometimes it seeps out.
No, no. Again, as I just mentioned, you have to follow proper protocol, Dr. Shibika. You can't say that no matter how much I am following the protocol, it is going outside the canal. It cannot happen. That is the reason, that is the whole point of this whole lecture today. I have mentioned about the like irrigation. A day before yesterday, Dr. Anu gave a very wonderful lecture on this particular like 3D, on the 3D this thing, what is it, 3D cleaning and shaping. So in that, like, she has beautifully mentioned about the role of the close ended needle. So and then again the again here again the yeah, this one, the role of determining the correct working length comes to play. So if you follow the protocol, it cannot happen. If at all it happens, like if the ecchymosis happens, like if the extrude, it must be because of the extrusion of the hypo, right? And then I've already mentioned in the slide there, like you can just dilute the dilute the irrigant with the help of with the help of saline and water, or you can just like inject like you can just inject some this one saline inside the canal to reduce the effect of the irrigant. That's what you can do, and you can just give some analgesic and antibiotic to give comfort to the patient. It should resolve eventually.
Ashmita Sharma is asking how to do irrigation for open apex cases.
Open apex cases, again, like it's advisable not to use the high concentrated high concentrated sodium hypochlorite in those kind of cases. Again, use of the side vented needle, little short of the working length is gonna help, and the the diluted one, like not the full concentrated, not the full concentrated hypo is advisable in this kind of cases.
Dr. Akash Chauhan is asking, what if calcium hydroxide base sealer goes beyond apex? Will it cause pain?
Of course, anything that is going beyond the apex is going to cause discomfort to patient. Even if the saline is going outside with the pressure, then the patient is going to have some discomfort. Okay, although like it might not cause like a big, like the tissue damage or anything, but then still some kind of discomfort is going to be there for the patient if anything goes beyond the orifice.
Okay. There's a question by Osman. How can we negotiate complete calcification canal?
This is another like big topic, okay? See, make a use of ultrasonic tips, okay? See, there was one very good lecture yesterday by Dr. Mallika yesterday on the topic complex anatomy. Please go through that lecture also. But just to give you a brief, idea about it, you can make use of this thing, ultrasonic tips, and along with the, you can use the EDTA, use this pilot files like dfinder files and C pilot files. Yeah, these are the like few tips I can give you as for now.
There is a question by Sirisha. How do we work with a vertical thermophil and prevent extrusion? And lateral compaction is what I use constantly. How good is vertical compaction and methodology and ease?
Vertical compaction is always better than the lateral like cold compaction, okay? But when you are talking about the what if they prevent the extrusion, the only way to prevent extrusion is to determine your what do you say this determine your working length till the apex, till the apical foramen. Again and again I am telling the same thing to you guys, with the help of apex locator, you do not over instrument, okay? That is like iatrogenic, that is like iatrogenically you are making the orifice like bigger, and that is how they like you will lose control of the material, obturating material, and that is eventually gonna get pushed out, okay? For that reason, from the very beginning you have to think about the accurate working length determination. Once you determine the working length nicely, then after that, like the anything that you are putting inside the canal, it won't get extruded outside the apical foramen or in the periradicular region.
Okay. And we are done with the questions, ma'am.
Thank you
Thank
so
you so much, ma'am. It was very great listening to you, and we are very grateful that you had time for us and shared us all your knowledge with us. And thank you to all the participants for actively engaging with the lecture of today. And thank you so much, ma'am, again.
Thank you everyone. I hope I also, like, somebody was asking me like how can they connect with us. You can follow Medical Aura page also, that is there in the Instagram, and also you can contact me via WhatsApp or email ID, or also Instagram is available, okay? So you can always contact us, me, or like any other our like one of the presenter of this Endo series. It has been wonderful. It was actually a wonderful experience to share my knowledge to you all. Thank you so much, everyone, and I
Ma'am,
hope it was helpful for you all this lecture.
absolutely. Yes, ma'am. Thank you so much, ma'am.
Okay, thank you, Dr. Vishaka. Thank you so, for being such a great host. Thank you.
Thank you.